Hey everyone, welcome back to Anatomy and Physiology Bit by Bit. This is your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching anatomy and physiology for 23 years, as of 2025. So thank you again for listening to this podcast. Today we are beginning the digestive system, which is typically chapter 25 of 29 in a two-semester A&P text. So we're very close to being through the entire course of topics for anatomy and physiology. But before we get into that, I want to take a few minutes to go back to the immune system for one more thing. Since the last episode, I've gotten a few emails asking me to further explain autoimmune disease. So I'm going to do that first, then we'll get into the digestive system. So a quick thank you to the following listeners: Josie from San Antonio, Texas, Aidan from Manchester, England, and Gretchen from Melbourne, Australia, for emailing me with this question. Okay, so autoimmune disease. Just to review immune for a second, imagine your body as a fortress: walls, guards, watchtowers, the whole bit. And inside you have a defense force, and that's your immune system. This army is trained to recognize and destroy invaders. And those would be viruses, bacteria, parasites, and anything else that doesn't belong. But what happens when the guards get confused? When the body's own defense system mistakes parts of that fortress for the enemy? That's what happens in an autoimmune disease. The immune system misidentifies healthy tissues, your joints, your skin, your organs, for example, as foreign invaders, and it launches an attack. The result? Inflammation, pain, and damage to your own body. Autoimmune diseases are surprisingly common. There are over 80 known types, and they affect about 1 in 10 people. 80% of those are biological females. That's a staggering number, and yet we're still working to fully understand why they occur. So let's break it down a bit. In a healthy immune system, there's a tight system of checks and balances, something called immune tolerance. That teaches your white blood cells to recognize the difference between self and non-self. We talked about this in the last episode. Think of it as a training or a boot camp. Cells that can't tell the difference are usually destroyed before they ever see action. But in autoimmune disease, that training breaks down. Some theories suggest it's a genetic predisposition, a kind of inherited risk. Others point to environmental triggers: viral infections, stress, certain medications, or even exposure to sunlight in diseases like lupus. It's probably not just one cause, but a combination of genetics, environment, and immune system glitches. So what does it look like in real life? Let's take an example: type 1 diabetes. In this condition, the immune system targets and destroys the insulin-producing cells of the pancreas. Those are the beta cells of the pancreatic islets. Without insulin, your body can't properly regulate blood sugar, leading to dangerous spikes and crashes. Another example is rheumatoid arthritis, where the immune system attacks the lining of your joints. The result for that? Painful swelling, stiffness, and over time, erosion of the actual joint surfaces themselves. Another common autoimmune disease is multiple sclerosis. In MS, the immune system attacks the protective covering of the nerves in the brain and spinal cord, which can lead to muscle weakness. We know that protective covering is myelin. Multiple sclerosis is a demyelinating disease. Not only do you get muscle weakness, but you get vision problems and you get difficulty with coordination. Perhaps the most infamous autoimmune disease is systemic lupus erythematosus, or lupus. This disease can affect almost any organ. It could be skin, joints, kidneys, the heart, and it can be unpredictable, with flares and remissions that make it challenging to manage. Autoimmune diseases are chronic, meaning they last a long time, often for your entire life. But they're also manageable. Early diagnosis is key, and treatments often involve medications that suppress the immune system, like corticosteroids or newer drugs that target specific immune pathways. The goal isn't to turn off the immune system, because we still need it, but to calm it down so it stops attacking the body. Living with autoimmune disease can be difficult, not just physically, but emotionally. There's These are often invisible illnesses. So from the outside, a person might look fine, but on the inside, they might be fighting fatigue, joint pain, or organ damage. And a lot of times, the people around them, they just don't understand. There's still a lot we don't know. Like, why does the immune system turn on itself? Why are women disproportionately affected? And how can we restore balance without shutting down the immune defenses that we still need to protect ourselves from pathogens? Well, researchers are exploring new frontiers, everything from the gut microbiome to personalized immunotherapy. And this is all in hopes of finding better answers. Until then, awareness, support, and compassionate care are some of the best tools that we have for autoimmune diseases. So the next time you hear someone mention lupus or MS or even celiac disease, which we haven't talked about, that's when you have an intolerance to gluten. Remember, these aren't rare, and they're not just all in someone's head. They're the result of a powerful system gone slightly haywire, even though it's a system designed to protect us. All right, so I hope that helps to understand autoimmune diseases a little bit better. Thank you again to Josie, Aiden, and Gretchen for sending me an email and asking me. I really appreciate you reaching out. One of my favorite things to see when I get up in the morning is an email from a listener asking me questions. We're going to take at least a couple of episodes to completely make our way through the digestive system. It's a pretty big system with lots of organs. So basically, our cells and tissues are working 24 hours a day to execute their various functions. And to do that, they need energy. We use our digestive system to consume the energy that they need to function. Our digestive system is a one-way tract, meaning we consume nutrient-containing solids and liquids at one end, and we excrete waste products and non-absorbable materials from the other. The one-way path taken by our consumed contents is a muscular tube called the digestive tract. You may hear people call it the alimentary canal. That is also correct. It begins at the mouth, which we call the oral cavity, and it ends at the anus. The anatomical structures and organs of the digestive tract, in the order food and water travel, are the oral cavity, the pharynx, the esophagus, the stomach, the small intestine, and the large intestine, which includes the rectum and the anal canal. The beginning of the tract is considered proximal, and the end is considered distal. The region of the digestive tract composed of the stomach and intestines can more specifically be called the gastrointestinal, or GI tract for short. There are many other structures that contribute to the digestive system's function as well, but they're not actually part of the digestive tract, which means food doesn't go through those organs. So we call them the accessory organs of digestion, and they include the teeth, the tongue, the salivary glands, the pancreas, the liver, and the gallbladder. And when we get to the small intestine, we're going to see that it's divided up into three sections. From proximal to distal, they are the duodenum or duodenum, however you want to pronounce it is fine by me, the jejunum, and the ileum. Now, the ileum here is spelled I-L-E-U-M, as opposed to your hip bone's ileum, which is I-L-I-U-M. So make sure you get that distinction down. That's an important one. The duodenum is the shortest. It's about 25 centimeters long. It's C-shaped, and it bends medially on its way to becoming the jejunum, which is the middle section of the small intestine. So basically, the duodenum is the first part of the small intestine. The stomach is emptying its contents directly into the duodenum. The jejunum is between 1 and 1.7 meters long, and the jejunum eventually gives way to the ileum. That's the longest section of the small intestine, which can be up to 2.7 meters long. It's going to empty its contents into the beginning of the large intestine, which is a large pouch called the cecum. Now, what you'll notice when you look at a cecum, and I can post some images on Instagram so that you can follow along a little bit, is a worm-like projection heading in the opposite direction that the contents are going to move. And that is called the vermiform appendix. Vermiform means worm-like. It's a dead end, it's blunt-ended. It does not contribute to digestive processes, but it does contribute to the immune system because it has immune tissue and lymphatic tissue. After the cecum, we start the colon. The colon is divided up into 4 sections, with some named for the direction the contents are traveling. The first section goes from the cecum all the way up to the region of the liver, and that is the ascending colon. Contents in it are moving superiorly, so we call it ascending. Once it gets to the liver, the ascending colon is going to make a hard 90-degree turn medially. That turn is called the right colic flexure. Sometimes you'll see people call it the hepatic flexure, especially if they're reading an x-ray. The next part of the colon that goes across your body from the liver to the spleen is called the transverse colon. The transverse colon then makes a hard inferior 90-degree turn, becoming the descending colon. That turn is called the left colic flexure, or sometimes you'll see splenic flexure because it's in the region of the spleen. The descending colon is named such because the contents are descending, they're moving inferiorly. The transverse colon is called such because it's in the transverse plane of your body. At about the level of the hip bones ilium, not the small intestine's ilium, the hip bones ilium, the descending colon becomes the sigmoid colon as it takes a medial turn, then an inferior turn, making an S shape. From the sigmoid colon arises the rectum in the midline of the body, anterior to the sacrum. The rectum is about 15 centimeters long. Finally, the last 3 centimeters or so of the digestive tract is the anal canal. The anus itself is the most distal part of the anal canal, and it is the exit point for digestive wastes. The digestive system's main function is to extract nutrients and water from our food and liquids. There are 5 different processes that contribute to that function. The first is ingestion, which is simply the process of taking food into the digestive tract. To put it simply, eating and drinking. The second may be a bit confusing because it's actually called digestion. Even though some people will use the term digestion to refer to everything happening to the food in our bodies, that's not really the case. Digestion is just breaking down food into smaller parts. We do this mechanically and chemically, so digestion is breaking things down. Mechanical digestion is simply taking something big and breaking it down into smaller parts physically. Chewing is an example of mechanical digestion. Chemical digestion refers to chemical reactions resulting in large molecules being broken down into smaller molecules. For example, an array of enzymes catalyze chemical reactions that break down complex carbohydrates into simple sugars. They also break down proteins into amino acids. Fats can be broken down into monoglycerides and fatty acids, and nucleic acids can be broken down into nucleotides. Think about the things that we're consuming. We're consuming carbohydrates, sugars, starches, those things like plants, the cellulose of a plant's cell wall, potatoes, rice, cereals, flat out sugar. Those are carbohydrates. We need to break those down into small, simple sugars like glucose and fructose so that we can utilize them to make ATP. Proteins. Proteins, as we know, are amino acids bound together by peptide bonds. There are only 20 amino acids, and we have a lot of proteins that we need to make in our bodies, like actin and myosin and troponin and tropomyosin, and the proteins that make up our protein-based hormones and neurotransmitters. The proteins that make up our receptors and our cell adhesion molecules and our ion channels, all in our plasma membrane. Not to mention plasma proteins that bind the lipid-soluble hormones so that they can be water-soluble and flow through our blood plasma. All of these things are proteins. We consume proteins, but we don't absorb them as proteins. We break them down into the amino acid building blocks that make those proteins, and then we use those building blocks to build our own proteins. We consume a lot of fats, butter, oil. All of those things are fats. There's fats in a lot of the things that we eat. They could be plant fat, they could be animal fat. Fat has a lot of calories per gram, twice as much as proteins and carbohydrates. So there are a lot of really good energy sources in fats. And also nucleic acids. If we eat things that are plants or animals, then we're going to be consuming DNA and RNA. So we need to break that down too into the nucleotides, and then we can use those nucleotides to make our own DNA and RNA. All right, so that's digestion. Absorption is the process of moving the molecules of the nutrients from the lumen of the digestive tract through its epithelial lining and into the blood plasma or lymph. We're also going to compact everything. Compaction is the preparation of our waste or feces. We do this by absorbing most of the remaining water and compress the remaining indigestible and unabsorbed material. And finally, defecation, which is the expulsion of feces from the rectum and the anal canal. So essentially, the digestive system is how we import all of the nutrients that we consume, get the energy from it, so that we have all the ATP we need to regulate our own metabolic processes. In order to understand that fully, we have to go down to the smallest parts of our digestive system. So I want to talk about histology, the actual histology of the digestive tract. Okay, you've heard it a million times, and not just from me, but structure tends to dictate function in anatomy and physiology. The digestive system is no different. Histologically, the tissue lining its lumen is going to change as we go through the tract. So let's take a look at the histology of the digestive tract. We'll talk about that. Again, I will post some images on Instagram so you can follow along. Let's begin with what most regions of the digestive tract have in common. Inferior to the diaphragm, there are 4 distinct histological layers of each section of the tract. From superficial to deep, they are the serosa, the muscularis externa, the submucosa, and the mucosa. Recall that the abdominopelvic cavity is lined with a 2-layer membrane called the peritoneum. Between those 2 layers is a fluid-filled space called the peritoneal cavity. This is just like the pattern we see in the heart and the lungs with the pericardium and the pleura. The layer that is attached to the inside wall of the cavity is the parietal peritoneum, and the layer directly attached to the abdominopelvic organs is the visceral peritoneum. That visceral peritoneum is also known as the serosa, or serous membrane. The serous membrane itself consists of 2 layers. The deep layer is areolar connective tissue, and like the visceral pleura and the visceral pericardium, the superficial layer of the epithelium is called mesothelium because it arises from the embryonic mesoderm. The serosal cells secrete the peritoneal fluid that fills the peritoneal cavity, as well as initiates defense mechanisms, including inflammatory and immune responses. Since the serosa is the visceral peritoneum, the segments of the digestive tract that exist superior to the diaphragm don't have a serosa. Rather, the fibrous connective tissue surrounding them is called the adventitia, and it connects them to nearby organs. So the serosa only exists in the sections of the digestive tract that are in the abdominopelvic cavity. The layer deep to the serosa is the muscularis externa, which consists of multiple layers of smooth muscle that contract to propel digestive contents distally through the tract. They also contract to mix up the contents of the digestive tract. Now, the stomach has 3 layers of smooth muscle in the muscularis externa: a circular, a longitudinal, and an oblique. But every other region only has 2, circular and longitudinal. Only the stomach has an oblique layer of smooth muscle in the muscularis externa. Watch out for that. That's a good test question. The longitudinal layers propel contents distally, while the circular layer constricts to mix the contents, increasing their contact with mucosa and preventing them from moving backward.
Bombas makes the most comfortable socks, underwear, and T-shirts.
Warning, Bombas are so absurdly comfortable you may throw out all your other clothes.
Sorry, do we legally have to say that?
No, this is just how I talk, and I really love my Bombas.
They do feel that good. And they do good, too. One item purchased equals one item donated.
To feel good and do good, go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
In some areas, the circular layers form sphincters that function as valves to regulate the movement of contents from one region of the digestive tract to the next. As we move a little bit deeper, we see the submucosa. That's the next layer. The submucosa is a layer of loose connective tissue between the muscularis externa and the mucosa. The blood vessels, nerves, and lymphatic vessels that serve the mucosa exist in that submucosa. Sometimes you'll find goblet cell-containing glands that extend from the submucosa into the mucosa so that they can secrete mucus into the digestive lumen. The deepest layer, lining the lumen of the digestive tract, is the mucosa. It's also known as the mucous membrane. 3 different tissues make up the mucosa. On the luminal side, we first have the epithelial tissue. That's what's lining the actual lumen. It is anchored to a layer called the lamina propria, which is a connective tissue layer. Deep to that is a thin layer of muscle called the muscularis mucosae. This muscle doesn't propel digestive contents, but it contracts in a way that wrinkles the mucosa, increasing its surface area in the lumen. The increased surface area maximizes capacity for absorption and secretion. So absorption of digestive contents and being able to secrete enzymes and water into the lumen. The mucosa of the digestive tract also contains the mucosa-associated lymphatic tissue that we discussed in the lymphatic episodes. The mucosa is also the most variable layer from region to region. The epithelium of the mouth, pharynx, esophagus, and anal canal is stratified squamous epithelium, mostly non-keratinized. That epithelium protects the organs from the physical trauma of solid contents moving through the tract, things that you're swallowing. The stomach and intestines, where most ingested contents are liquefied, are lined with simple columnar epithelium. They don't have to worry about the trauma of solid stuff because it's already been converted to a liquid called chyme at that point. The epithelial cells of the small intestine have microvilli, which are specialized for absorption and secretion, and we call that the brush border. So if you go back to many episodes ago, very early in this podcast, the first 5 episodes or 6 episodes, you'll see episodes about the cell. And I talk about surface features on the cell, and one of those things is microvilli. They are extensions of the apical surface of the cell that increase the surface area of that cell's plasma membrane. That increases their capacity for absorption and secretion. Okay, now that the histology is covered and we know what the lining of the lumen looks like and what the submucosa and the muscularis looks like, now we can talk about the actual tract that food is taking from when it enters your body to when it leaves your body. This is called the digestive tract, and this is the actual tube that food and water goes into. It starts at the mouth, ends at the anus, and we're going to start at the mouth, talking about it from section to section. We also call the mouth the oral cavity and buccal cavity. It ingests food and prepares it to be swallowed. The muscles and other tissues of the cheeks and lips hold the food in your mouth while the tongue, teeth, and salivary glands convert the ingested food into a swallowable mass called a bolus. The tongue and teeth work together to mechanically digest food by compressing it and breaking it up into smaller pieces. The process of chewing we call mastication. You might remember from previous episodes about skeletal muscles that we had some muscles of mastication. Some of them were the masseter, the temporalis, the pterygoid muscles. Go back into some previous episodes on muscles and see if you can review some of those. Chewing is an automatic reflex, which means you don't have to think about doing it, but you can stop it if you like, unlike an involuntary reflex that you have no control over, like when you get your patellar ligament hit with a hammer and your quadriceps muscles contract. In addition to the sensory functions that we discussed in the taste episode, the muscular tongue also secretes mucus and enzymes to help chemically digest food. In addition to that, it manipulates the food while it's being chewed to make sure it stays between the upper and lower teeth. When the food is adequately prepared to be swallowed, the tongue maneuvers the bolus toward the pharynx and initiates the swallowing process. We call swallowing deglutition. Whether we're eating or not, the mouth contains an exocrine secretion called saliva. Saliva has multiple functions and is secreted by salivary glands. Among salivary functions are keeping the mouth moist and clean, making sure bacteria are not allowed to proliferate unchecked, dissolving tastants so that we can taste our food, chemically digesting some fats and carbohydrates, and lubricating the bolus with water and mucus so it's easier for us to swallow. Saliva is made up of about 99.5% water and is mostly a neutral solution that may be very slightly acidic. The solutes in saliva are mucus, electrolytes, 2 digestive enzymes, and antibacterials like lysozyme and the antibody immunoglobulin A. One of the digestive enzymes is salivary amylase, which starts the breakdown of starch. Starch is a complex carbohydrate typically found in wheat, rice, potatoes, and corn. The other enzyme is lingual lipase, which is secreted by the tongue. Lingual means tongue. Lingual lipase begins the breakdown of fats in the mouth, is swallowed with the bolus, and continues to chemically digest fats in the stomach. There are 2 different classes of salivary glands. The first is called intrinsic salivary glands because they're inside the oral cavity. These are small glands found throughout the inside of the mouth. They can be associated with the tongue, lips, palate, and cheeks. They secrete saliva all the time to keep the oral cavity moist and to keep oral bacteria in check. The second class is called extrinsic salivary glands because the glands are outside the oral cavity. There are 3 extrinsic salivary glands, each found bilaterally. They are the parotid glands in the vicinity of the masseter muscles, the submandibular glands inferior to the mandible, and the sublingual glands under the tongue. Each of these secrete their saliva into ducts that extend into the oral cavity. Salivation is stimulated by the parasympathetic division of the autonomic nervous system. The salivatory nuclei, the origin of those parasympathetic fibers, are found where the pons and medulla oblongata meet. The nerve fibers run in 2 cranial nerves, the facial, which is cranial nerve 7, and the glossopharyngeal, which is cranial nerve 9. Notice that when you get embarrassed or nervous, your mouth feels dry. This is because the sympathetic innervation of the salivary glands may actually be inhibitory, decreasing salivation. When the bolus is finally ready for swallowing, the tongue voluntarily manipulates it toward the posterior oral cavity, where it exits into the oropharynx through the fauces. F-A-U-C-E-S, fauces. From the respiratory system, we know how the pharynx leads to the larynx and trachea, but it also leads to the esophagus, which carries food and water to the stomach. The muscles of the pharynx participate in swallowing as they constrict to push the bolus toward the esophagus. Like most of the digestive tract, the pharynx has a layer of longitudinal muscle and a layer of circular muscle. The circular muscle comprises the 3 pharyngeal constrictors, the superior, middle, and inferior. To prevent air from entering the esophagus, the inferior constrictor contracts when you're not swallowing. Now, moving the bolus toward the pharynx is actually the beginning of swallowing. Swallowing has a voluntary component and an involuntary component. So we'll take a look at swallowing, which we call the deglutition reflex. Swallowing begins in the mouth, it runs through the pharynx, and then is finally completed by the esophagus. So I think before we get into the specifics of swallowing, we should talk about the anatomy of the esophagus. The esophagus is a long, muscular tube that extends from the laryngopharynx through the posterior thoracic cavity, piercing the diaphragm and ending in the stomach. The hole in the diaphragm that the esophagus passes through is called the esophageal hiatus. You might have heard of a hiatal hernia. That's when a piece of the stomach gets stuck in that esophageal hiatus. We'll talk about that later because it has some repercussions that are specific to the stomach and the esophagus together. Since it's close to the heart, the space the bolus passes through to get into the stomach is called the cardiac orifice. In fact, that region of the stomach that's closest to the esophagus is called the cardia. The cardiac orifice is regulated by a circular band of muscle called the lower esophageal sphincter, or LES. Sometimes you'll hear it called the cardiac sphincter because of where in the stomach it is associated. The mucosa of the esophagus consists of non-keratinized, stratified squamous epithelium, with esophageal glands extending from the submucosa into the lumen of the esophagus. Those esophageal glands are going to secrete lubricating mucus into the esophageal lumen. Remember, I said earlier that there's no serosa in the thoracic esophagus. And in fact, the muscularis externa has a quality unique to the esophagus. In the superior one-third, the muscularis externa is only skeletal muscle, meaning it's voluntary. The middle one-third is a combination of skeletal and smooth muscle. And the inferior one-third is only smooth muscle. This is a key region of the digestive tract as the motility transitions from voluntary to reflexive to involuntary. Surrounding the muscularis is adventitia, which is the connective tissue covering of organs and blood vessels. The esophageal adventitia is continuous with that of its neighboring structures like the aorta and the trachea. Deglutition is a three-phase process carried out in both a voluntary and involuntary manner by nearly 24 different muscles. The first phase is the oral phase, and it is the only phase under voluntary control. It is simply the process of moving the bolus to the fauces so it can enter the oropharynx. Remember, the fauces is like the doorway from the oral cavity to the oropharynx. The second phase is the pharyngeal phase, and that begins the deglutition reflex, which is initiated when sensory receptors surrounding the fauces are mechanically stimulated by the bolus. Sensory nerve signals are generated, and they travel on sensory or afferent neurons to the central nervous system's swallowing or deglutition center of the brainstem's medulla oblongata. This integrating center triggers motor nerve signals along motor neurons or efferent neurons to the pharyngeal muscles, acting as the effectors of this reflex. So remember, reflexes have receptors, afferent or sensory neurons, an integrating center in the central nervous system, motor or efferent neurons, and effectors. That is the 5 components of a reflex arc. These effectors execute multiple actions. First, they draw the bolus through the fauces into the oropharynx. Next, the pharyngeal muscles of the soft palate and the uvula contract to elevate them and close off the boundary of the oropharynx and the nasopharynx. This prevents food and liquids from moving superiorly into the nasopharynx. Now, you probably know, just like anybody else, that sometimes that doesn't work, and food or liquids go up the nasopharynx and end up coming out your nose. The infrahyoid muscles also contract, elevating the larynx so it meets the epiglottis, which covers the opening of the larynx. We don't want food and water to get to the trachea, so we close or cover the opening of the larynx, leading to the trachea, so that doesn't happen. Now, in addition to the epiglottis action, the vocal cords adduct, meaning they close, and that also helps to block foods and liquids from entering the trachea. When food or liquids do enter the airway, it's called aspiration, and even if they don't block the trachea completely, it can cause a dangerous infection called aspiration pneumonia. So it doesn't have to cause choking to be dangerous. Not only does the pharynx rise, but also it widens. The pharyngeal constrictors then contract in order from superior to inferior, squeezing the bolus toward the upper esophageal sphincter. Once it makes its way through that sphincter, the bolus enters the esophagus. During this phase of swallowing, inhibitory signals are sent to the medulla oblongata's respiratory center to inhibit breathing and minimize the likelihood of aspiration. Because if you think about it, if air is coming from your lungs up your trachea, while you're trying to swallow, it's going to be really hard for the epiglottis to block the larynx, because air is going to be coming up and forcing that epiglottis up, because it is blunt-ended. It doesn't have an attachment on its distal end. The third and final phase is also involuntary and is called the esophageal phase. As the bolus passes through the upper esophageal sphincter, it stimulates stretch receptors in the myenteric plexus of the esophageal wall. This myenteric plexus is a network of neurons in the wall of the esophagus. If we can stimulate stretch receptors, we can continue the reflex to stimulate more effectors to contract and squeeze the bolus more. That part of the deglutition reflex is a sequential wave of contractions from proximal to distal that we call peristalsis. Peristalsis squeezes the bolus through the esophagus toward the stomach. The circular muscles of the esophagus contract, which push the bolus downward. Meanwhile, the slightly distal longitudinal muscles also contract, shortening and widening that segment of the esophagus so the bolus can't move into it. Eventually, the bolus makes it to the relaxed lower esophageal sphincter and passes through the cardiac orifice into the stomach. This is the first of many reflexes we're going to see that are regulating the movement of contents through your digestive tract.
Bombas makes the most comfortable socks, underwear, and T-shirts.
Warning, Bombas are so absurdly comfortable you may throw out all your other clothes.
Sorry, do we legally have to say that?
No, this is just how I talk, and I really love my Bombas.
They do feel that good. And they do good, too. One item purchased equals one item donated.
To feel good and do good, go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
Okay, I think that's enough for this episode. We can pick up with the stomach and finish the digestive system in the next episode. That's going to include the rest of the digestive tract, including the stomach, small intestine, large intestine, rectum, and anus, and the accessory organs of digestion that are in the abdominal cavity, which include your liver, gallbladder, and pancreas. So we'll get into that in the next episode. Thank you so much for listening. I really appreciate your time. I hope this is helping you get your B or better in A&P. I want to thank everyone who emailed me with questions about the immune system. Good luck. I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media. Don't forget to check out my Instagram account and my YouTube channel, both called Student Help for AP. I'm posting a lot of stuff on there right now that you can watch and that will hopefully really help you understand this A&P stuff. Very special thank you out to my family, Bucks County Community College, and McGraw-Hill Education, where you can find my tutor video-based textbook alternative Anatomy and Physiology digital suite, already being used by several colleges and universities throughout the United States.